Phineas Gage was a railroad foreman who an explosion like catapulted this large iron rod through his skull and his frontal lobe, and somehow he lived miraculously. And people then we now know the frontal lobe has a lot to do with behavior and emotion and complex thought. They didn't really know this back then, but people said that he had these dramatic behavioral and intellectual changes. It's probably the case that that was exaggerated, but what is true is he certainly sparked a intellectual like revolution in neuroscience where this debate on cerebral localization, kind of reverse engineering the brain came about. So there's a big breakthrough for a lot of psychologists and neuroscientists of the day. Anywho, we're talking about lesions. So don't ever think of lesion anytime there's damage, whether it's, you get smacked in the head or there's a stroke or, you have multiple sclerosis and you demyelinate a region or there's a tumor, etc. Anytime you have damage, we're just thinking, again, reverse genetics, right? Gene X, we want to know what it does. We do a knockout. Your ears get really big. Oh, okay, Gene X had something to do with keeping your ears normal. We're doing the same thing for all of the regions of the brain and the spinal cord and the nerves and whatnot. Frontal lobe, so like Phineas Gage, we know that concentration is going to be suspect. Judgment, if it's the precentral gyrus and the posterior aspect of the frontal lobe, the primary motor cortex. If it's central is going to be if it's an ACA stroke. Lateral, it's going to be if it's an MCA stroke. Lateral is the most common. You're going to have arm and face contralateral weakness. But the face, we're also talking about the muscles for the voice box. So you might have trouble speaking and you might have trouble swallowing. But dysarthria is difficulty getting the words out, like from a mechanical perspective. Primitive reflexes also might emerge. So things like the Babinski reflex, where you point your toes up. It's weird. Your body always wants to point the toes up when that reflex is stimulated, but it's your frontal lobe, for whatever reason, that inhibits this. It does the same thing we're going to see in a second with the red nucleus. So it's constantly telling the body, no, don't do that, don't do that, don't do that. Well, if you take out the frontal lobe, like you get a giant rod through the head, you don't have that voice of reason, and so a lot of these primitive reflexes will reemerge. So dysarthria is because we don't have the muscles to generate speech, but dysphagia is that we don't have like the certain intellectual capacity to generate speech. So Broca's area in the frontal lobe, the language is almost always on the left side. This is going to be broken speech. Actually, this is not fluent aphasia. So this is just broken speech. The person knows what they want to say, but they just can't get out the right words. There's gonna be a lot of pausing, a lot of stuttering, a lot of Wernicke's aphasia is now going to be like a word salad. So they will just talk out now, brown cow, there you go, big man, hello, there you go, good kitty. And it's just, they're saying a lot of things, and I'm kind of exaggerating, right? There might be some rhyme or reason, but for the most part, it's going to be nonsensical, but it comes out very fluently. So this is the fluent aphasia. Broca's, Wernicke's, definitely know what those are with respect to the sylvian lateral fissure and the central fissure. So parietal lobe lesions. So dominant, if you're right-handed, you probably have left dominant brain. If you're left-handed, you might have a right dominant brain. Again, for most people, the language is nevertheless going to be on the left side. So for the dominant part of your brain, if there's a lesion in the parietal lobe, you'll get Gerstmann syndrome. Agraphia, so you're going to have difficulty writing. Acalculia, you're going to have difficult doing mathematical equations. Agnosia, you just can't recognize things. You might not be able to recognize your own hands. And left-right disorientation is exactly what it sounds like. You have a hard time differentiating the left side of your body from the right side of your body. If it's the non-dominant lesion, just agnosia of the contralateral side of the world. For the post-central gyrus, we have a lot of the density of sensory neurons receiving input from the DCML and the spinothalamic tract. This is going to have the same homunculus sort of geography where central ACA is going to be for legs, and then the MCA is going to be for the arms and face. Occipital lobe lesion, so this is pretty much just vision. But the vision, you're still receiving light, right? It still goes through your optic nerve, optic chiasm, optic tract, medial lateral geniculate nucleus, superior colliculi, then the radiations. But when it gets to the optical lobe, you don't really know how to process it so much. So this is an artistic simulation of what it looks like for someone who's had a stroke in this region. Same here. You can recognize a lot of these things, but your brain's kind of confused. It doesn't actually know exactly what it's looking at, right? We might say like, okay, this is kind of a jacket and that's kind of a hat, but I don't understand where it is in context. And this is like a calendar, but it looks like Chinese characters. And you really just can't make heads or tails of it. And similarly, so these people are going to have face blindness, difficulty recognizing objects. They might have illusions or hallucinations. And for the cortical blindness, just to emphasize the macular sparing. So it depends what the issue is with the occipital lobe, but if it's likely a stroke in like the PCA or MCA, so both of those are actually going to supply the occipital lobe, PCA a little bit more, but they both will equally supply the part of the occipital lobe that has to do with the macular central vision. So if you have a stroke, it is likely that this will be spared. So you have macular sparing here. Your light reflex are going to be normal. These are reflexes. They don't really have much to do with your occipital lobe. This is just like the superior colliculi and whatnot. All right, temporal lobe. So temporal lobe, you might have, this is where hearing is processed. Tempo is in beat as in hearing. Wernicke's aphasia. Again, there might be a little bit of overlap. Broca's and Wernicke's and the arcuate fasciculus are kind of close by one another. But again, this is going to be fluent aphasia. If you have damage to your amygdala, you might get Kluver-Bucy syndrome, where you have hypersexuality and hyperorality. And I just thought of this picture right here. This can be caused by, among other things, herpes simplex encephalitis, HSV. Hippocampus takes like short-term, like new memories and converts them into long-term memories. So if we don't have this, we're going to have anterograde amnesia. The mammillary body is something that's damaged if you're an alcoholic. If you're an alcoholic, you have a vitamin 1 thiamine deficiency, and you might get Wernicke-Korsakoff. Wernicke is talking about the damage to the vestibulocerebellum, so you're going to get ataxia, and you're going to have like nystagmus and certain vision issues. But Korsakoff, I always think of like off your rocker. People are going to confabulate. They're going to make things up. Why are they making things up? Because they have both anterograde and retrograde memory, and the brain is sort of striving for some sort of coherence, right? They might get up, go to the other room because they want a soda, but they get to the other room, they don't remember why they're there, right? They don't remember wanting a soda. And you ask, hey, why are you here? They'll make up some ridiculous story so that they seem rational. I think this is both conscious and subconscious. Like it is a defense mechanism or something. But so I think of people being off their rocker. Memory loss leads to confabulation. Cerebellar lesions: don't eat greasy foods. Don't eat greasy foods. These two together are sometimes called the interposed nuclei. So if we have a lateral lesion, whether in the posterior lobe or on the anterior lobe, this is the cerebrocerebellum. So if I want to kick us, I'm lining up to do like a penalty kick, for in soccer or something, and I want to plan exactly how to kick the ball, how to strike it. This is going to be the cerebrocerebellum that's kind of fine-tuning these movements. And again, this is the dentate nucleus because this is the most lateral one. If I have a medial lesion in the cerebellum, it's going to be the interposed nuclei, which is again either the globose or the emboliform, or it can be the fastigial nucleus. This can damage the vestibulocerebellum or the spinocerebellum. So here we have the spinocerebellum. The spinocerebellum is receiving inputs from proprioceptive, like dorsal column. And so we might get something like truncal ataxia. We might get like a wide base gait. And if we damage, also kind of centrally, but maybe not the floccular nodular lobe is kind of a weird place. But if you damage the floccular nodular lobe, this is also receiving inputs having to do with balance, having to do with people can develop vertigo if either of these are damage is occurring here. But the floccular nodular lobe receives inputs from the eyes and from the vestibular system. So you can get nystagmus, and you can get a truncal ataxia as well. Basal ganglia lesions. So the basal ganglia, a bunch of different parts, went over this in the last video, but the subthalamic nucleus is part of the indirect inhibitory pathway. it is specifically trained to activate that which is inhibiting the thalamus. The thalamus is a yes man trying to activate the cortex, whatever it wants to do. And so if you take out this part of the indirect pathway, well, then you have less inhibiting, which means you're going to have more movement. That's why this is a hyperkinetic disorder. We call this hemiballism, because you're kind of like going ballistic. People's arms are just kind of, shaking uncontrollably. You can kind of see this right there. The substantia nigra, now this plays a central role in both the direct and indirect pathway. But initially on, that's still true what I said, but I was thinking about Huntington's. All right, substantia nigra, it is, so we have the reticulata. Reticulata is going to be for retarding movement. That works with the GPI to inhibit the thalamus. But then we have the substantia nigra compacta, which is what has the dopamine. So this is going to pour dopamine, D1 receptors for the direct pathway, D2 receptors for the indirect pathway. So in other words, it's amplifying the direct pathway and it's inhibiting the indirect pathway. Inhibiting the inhibitory pathway just means activation. Amplifying the direct pathway just means activation. So it is pro-movement, the substantia nigra compacta. If you have Parkinson's, there's damage here, and so you're going to get hypokinetic or akinetic movements. We see this this shuffling gait, right, having a hard time moving. The striatum is what I was referencing a second ago. This plays a central role in both the direct and indirect pathway, as is the substantia nigra, but this is a little bit more central. The striatum in Huntington's is actually the indirect pathway is what's affected first before the direct pathway. So if this is the case, you don't have the indirect pathway and you're going to get these hyperkinetic movements, similar to hemiballism. Except this is typically unilateral and the other ones are bilateral. Lesions of the dorsal midbrain. So Parinaud syndrome is something that will develop if you get a lesion here. So it can be caused by, so we have the pineal gland. If you get a tumor of the pineal gland, this can press on it. Or if you have just hydrocephalus, typically non-commuting hydrocephalus, this can compress on it as well. A couple things to be damaged. The Edinger-Westphal nucleus is important for the pupillary light reflex, where if I shine a flashlight in your eyes, it's going to cause both your direct and consensual pupillary constriction. So you won't be able to constrict your pupil to light, but you can still constrict your pupil. If I push my finger close to your nose and your eyes track it, you will still constrict there. So we would say that there is a light-near dissociation, right? Because you're constricting for near, but you're not constricting for light. Edinger-Westphal nucleus is just for the light, not for the near. I don't exactly know the mechanism here, but the levator palpebrae is innervated by oculomotor cranial nerve 3. And if that's damaged, you get something called ptosis. Something I don't really understand here is that there's also inhibitory fibers there that are only damaged if you have a lesion of the dorsal midbrain. So you kind of get the opposite. You get this lid retraction, which is known as Collier's sign, like that. And you also have a vertical gaze palsy for reasons that I don't understand. So you have trouble moving your eyes vertically, which means they're a little bit kind of down, and that actually looks a little bit like a sunset. So sometimes these are called a setting sun or sunset eyes. And cool. Reticular activating system is also known as the reticular formation. It's just about maintaining consciousness. So if you damage this, someone might go into a coma. I mentioned the red nucleus earlier. So in the upper part of the midbrain, and it's important, the upper part of the midbrain, not the lower part of the midbrain, we have something called the red nucleus, which does a couple different things, but the most important one is it is going to innervate some of the flexors in our upper extremity. And it's kind of like one of these primitive reflex type things where it always wants to flex. So here's the red nucleus in the superior midbrain, thinking, hey, we should flex our arms. And it's up to your cerebral cortex to say, no, don't do that. That's a really bad idea. Don't flex your arms. And so normally you're just sitting there, you're probably not flexing your arms. What happens if I have a lesion right here? Well, I'm definitely not going to flex my arms then, because even if I wanted to, my red nucleus can't communicate, and so you're going to get this arm and wrist extension. On the other hand, if I have a lesion above the red nucleus, now the cerebral cortex is saying, don't flex, but that message isn't getting through. So the red nucleus left to its own devices is like, oh yeah, I'm going to flex all I want. Flex my arms, flex my forearms, flex my wrists. All right, so here, there's a couple different lesions that we're going to talk about. Probably the most important one is internuclear ophthalmoplegia. And if we break that down, internuclear, between nuclei, cell bodies in the brain, ophthalmoplegia, opthal, eye, aplesia paralysis. So it's going to be a paralysis due to communication between neurons. Let's run through this entire lateral gaze pathway. So let's say that our objective is to look to the right. The left frontal eye field is going to communicate, it's going to decussate crisscross. It's going to move over to the right PPRF. This goes to the abducens nuclei. And that is just going to, on this side, say, hey, you know what, let's go ahead and the lateral rectus muscle, cranial nerve 6, let's move this in this direction. That's exactly what happens. But we also need to get the left eye to look medially. So it's also going to move here through the medial longitudinal fasciculus, which is highly myelinated, and just spoiler, if you have MS, this is likely to be damaged. So anyways, we're going contralaterally, again, crisscross. This now goes to the oculomotor, which supplies most of the motor innervation of the eyes, importantly for the medial rectus, so that this can now turn medially. And if this one turns laterally and this one turns medially, you have a unison, both your eyes, this lateral gaze looking to the right. Okay, so that's how if everything works perfectly. But what if this is broken or this is broken, right? Left FEF or right PPRF, nothing's going to happen, right? You're stopping right at the beginning. You don't get any ability to look to the right. Okay, what if we have left MLF3? So in other words, we get the message from here to here, and then we get it from here, and that means this one can go ahead and look. So my right eye has no problem looking to the right, but the message never comes over here across the MLF. So the left eye just sits there. So it technically could be that it does cross, but then the oculomotor nerve is damaged. But more importantly, we can think of the MLF, and this is what we mean when we say internuclear ophthalmoplegia. We can't get between this nucleus and this nucleus, so we get a paralysis. Now, less importantly, but we'll talk about it, you could also have a right cranial nerve 6 issue, where we go from here to here, and then we cross fine, and then we go over here, and then this one looks medially, but there's damage somewhere along here, and so this actually can't look lateral. Good to know all of these, very important to understand this. This is the most important one. That's what we mean when we say internuclear ophthalmoplegia.